Welcome to the latest webinar hosted by United for Global Mental Health, our Mental Health for All webinar series. And I'm absolutely delighted. We have a fantastic panel here today and delighted to welcome guests joining us from across the globe. And I think it's such an important time as we're now almost at the end of September, end of August, and September World Suicide Prevention Month is almost upon us, with obviously the focus of all of our activities. Although suicide prevention is required every single day, 365 days of the year, it's vital that we shine a light on that month of September, and in particular on World Suicide Prevention Day on the 10th of September. So I'm delighted to share this on behalf of United for Global Mental Health. My name is Rory O'Connor. I am president of the International Association for Suicide Prevention, and we're really gearing up to a really active few weeks ahead. So I'm really excited about the conversation we'll have today. And no matter where you are, who you are, it'd be great if you could tell us a bit about who you are and on the chat, and so we have some idea of who's in our audience. It's always great to hear. And the format of the webinar over the next 54 minutes, I think it is now, is it's in three parts effectively. I'll introduce or ask our panelists, our four distinguished panelists, to talk about or say who they are. And then once we've done those introductions, we have a specific question to get us going for each of the panelists and their respective parts of the world. So we'll begin with those round of questions, and then we've an opportunity then, after those questions have been asked, to move on to then hopefully, if you can put questions you have in the chat, we can then collate those and hopefully ask some of those questions. So can I really encourage you to put any questions you may have or observations you may have about the work that you're doing, or some advice you would like from our experts here. Just put it in the chat and we'll try to get to your questions in that second bit. And then we've got a third bit, which is just a sort of a wee surprise. We just ask our panelists to give us a key message to end the webinar. So without further ado then, pleased to say, she's joined us. I can see it's great to see everybody adding who they are. Gillian, Melanie, every great people are adding to the chat, so we have some sense. That's brilliant to see, so thanks for that. So I'll just move on straight into hopefully inviting our panelists to say who they are. I'll just do it in the order that I have here. So Renato, would you start first? Introduce yourself, tell us a bit about who you are and what brings you here today.
Thank you very much, Professor O'Connor. I'm Renato Oliveira. I'm the Unit Chief for Mental Health and Substance Use at the Pan-American Health Organization, the regional office of the World Health Organization in the Americas. It's a great pleasure to be with all of you here and have the opportunity to discuss such an important public health topic for us here in the Americas. Thank you.
Fantastic. No, thanks, Renato. So, Shihadu, could you go next and tell us a bit about who you are?
Thank you so much, Professor O'Connor. My name is Judah. Oh, sorry.
Oh no, go on ahead, Judah. Go on ahead, Judah.
Okay, sorry. My name is Judah Njoroge. I'm from Nairobi, Kenya. I work as the Youth Engagement Officer in Basic Needs, Basic Rights Kenya, and also the founder of Integrative Wellbeing. I launched the Quality Rights campaign, which is very closely related to suicide prevention, and I'm very happy to be here and discuss that this amazing topic. Thank you.
Fantastic. So, Shahidu, do you want to go next? Oh, you're on mute. You're on mute.
Okay. Hi, dear all. Thank you very much, Professor Rory O'Connor, giving me that chance to be introduced with you. I am Dr. Mohammad Shahidul Islam from Bangladesh, and I am the Program Manager for Non-Communicable Disease Control Program under the Directorate General of Health Services, Bangladesh. And I usually work with mental health and disability with other issues also. So I'm taking the chair for the last 2.5 years, and I am working mental health activities.
Fantastic. Thanks very much. And our fourth panelist, last but not least, Mark.
Thank you so much. It's really a great honor to be with this group. I'm Mark Senior. I'm a psychiatrist and suicide prevention researcher at the University of Toronto in Toronto, Canada. And I'm here in my role as the lead for the Partnerships for Life initiative by the International Association for Suicide Prevention for the Americas.
Fantastic. Thanks, Mark, and thanks everybody for your introductions. And before we move into sort of the first question, I think it is worth reminding ourselves on sort of the theme of the webinar is creating hope through action. And when we at YASP, the International Association for Suicide Prevention, this is our third year of having that theme. And to our mind, part of our thinking around that was, if we looked at the previous, say, 10 years on suicide prevention, there was a lot about awareness raising, which is really, really important. But we thought we were at a stage then it was so crucial that we translate that knowledge from across the globe into action. And what's great about the webinar today and the work around decriminalization is, in the last few years in particular, we have seen so much action globally in a number of countries around the world in respect of decriminalization. Ghana, Pakistan, India, all making strides forward, and that's just to name 3 countries moving forward. And it's great to hear. I'll hear more about that today. So with that sort of presse, if presse is the correct word, I'm going to move straight to Renato. Renato, can you maybe tell us about the new strategy for improving mental health and suicide prevention was launched in the Americas in April of this year? Can you tell us maybe a little about the state of suicide prevention in the Americas, the strategy and how it will be implemented?
Yes, of course. Thank you for the question, Professor O'Connor. So, look, our member states here in the Americas, in the executive committee, they agreed that suicide prevention should be a major public health priority in the region of the Americas, and that's why, in fact, they worked together to put forward a new strategy on mental health and suicide prevention that will be discussed in a new forum now that has all the member states of the Americas together in September, which is the Directing Council. But let me mention to you the reasons why we affirm that suicide prevention is a public health priority in the Americas. We have looked into the data from that the different countries have been putting together, and in fact we see a 17% increase in the regional suicide rate in the Americas. We are the only region comparing with the other WHO regions where in fact you see the regional suicide rate increasing. We have countries here in the region of the Americas that have very high suicide rates. And in fact, we have some heterogeneity in the Americas, but there are particular sub-regions in the hemisphere that have either high suicide rates or ascending suicide rates. And I can give, for example, countries like in the Caribbean sub-region, we see very high suicide rates. But also if we looked into the southern part of the hemisphere, which are the countries of the Thousand Cone, we also see high suicide rates and suicide rates that continue to increase. When we look at those curves, we also see that women have a very sharp increase. So it seems to be a new phenomenon that we need to pay very close attention. We have high rates among the elder, but we also have high numbers of youth who are affected by suicide. We also know that although there is not much disaggregated data, but we know that there are subgroups that appear to be more affected than others. And I can give you examples that we see in some of the countries like indigenous communities, LGBT communities. And we should not forget also that we went through a pandemic, and that pandemic has affected important risk factors for suicide. So when we put all this together, we see a clear case for working with member states and making suicide prevention a public health priority. It's also important to mention that recently PAHO created a high-level commission on mental health and COVID-19, and the discussions of those commissioners who came from very different backgrounds. We had the ex-vice president of Costa Rica, the deputy secretary general of the Organization of American States, people with lived experience, academics, and in fact, suicide prevention comes again as an important priority, and it's one of the 10 recommendations of the PAHO High-Level Commission. So these are important reasons that we believe it's fundamental to advance this topic, Professor O'Connor. And the way that we are trying to advance this topic is really working very close to member states. And I'm sure some of my colleagues are going to elaborate more. You already mentioned a very important area that we need to support member states, which is to advance decriminalization of suicide. We have in this region the recent example of Guyana. Guyana is a country where suicide was a crime, and recently they passed a law where it's not a crime. So we hope that this will increase the possibilities of people to have access to treatment, and suicide prevention will be less stigmatized. There are also other important areas that we work together with member states. We work by supporting member states to look into the access of means of suicide, which is an important area for suicide prevention, helping member states to integrate also social emotional skills, working with the media, another important area. And to make it very brief, these are different areas that are included in the Live Life guide from the World Health Organization, and they help us to really support member states to advance this area. Thank you.
No, thanks a million, Renato. That was a really wide-ranging answer covering really important. A couple of key messages came to my mind there when you're speaking, is actually highlighting that increase in amongst female suicides, which is, I think we're witnessing that in a number of different countries now. And I don't think we understand enough about why that increase has happened or is happening, and it's a concern. Obviously, all deaths are a concern, but also really pleased to see the breadth of activity which is going on, because as we all know on this webinar, we need to operate at all different levels, from government right down to the individual, if we're really going to tackle this huge challenge that we have. So I'm going to move on now to our second questions. Shahidul, it's with you. The next question's with you. Okay, so we're focusing now on Bangladesh, and so I know that you've now got the National Mental Health Strategic Plan, I think covering the years 2020 to 2030, and that's part of that is about forming a national suicide prevention plan, and of course you're advising with regard to decriminalization as well as part of that work. Could you tell us a bit about what progress has been made on these fronts, and what more needs to be done to really realize both of these goals of the action plan and decriminalization?
Yeah, am I audible to you? Okay, nice. Thank you very much, Professor Rory O'Connor, and giving the chance to present our condition and status before you. And I'm feeling honored, actually. You know, Bangladesh is a country of 169 million people. And you also know that like other countries, like many countries around the globe, Bangladesh was up behind to address the mental health issues for long years. But since the last decade, there is a vibration, actually, to the dominant state to awake. So mental health is actually a priority issue in Bangladesh right now. So since you know maybe that Bangladesh records approximately 10,000 suicides per year, one of the leading causes of death among the young women, that's going to be steadily increasing. And suicide and suicidal attempts are classified as criminal offenses in Bangladesh, according to the Section 306 of the Indian Penal Code 1860, which Bangladesh inherited from a colonial tradition, about 118 years old law that is the backbone of the legal frame of Bangladesh. And that provides police with the authority to arrest and courts to punish people who attempt suicide. According to another section, 309, the penal code says, whoever attempts to commit suicide and does any act towards the commission of such offense shall be punished with simple imprisonment for a long term, which may extend to 1 year or with fine, or with both. So since we know that Germany was the first country to decriminalize attempted suicide, and most of the developed countries followed it, even Pakistan, the nearby country of Bangladesh, is a Muslim majority nation, decriminalized suicide in the last December 2022, most probably. Bangladesh is alone among the 8 South Asian countries where suicide and attempted suicide still is a crime. So people are generally afraid of sharing suicide intent or seeking help, admitting previous suicide attempts to avoid social and legal harassment. Even admitted patients leave hospital without completion of treatment. So there is a debate in Bangladesh on the issue of decriminalization of suicide and suicidal attempts. Some argue that without addressing fundamental issues such as national suicidal database, surveillance system, appropriate prevention strategy, and implementation of the research, decriminalization might not bring the expected outcome actually. Another argument is there, the decriminalization will provide better access to the health services, reduce stigmatization and guilt, avoid legal complication, and empower legal authorities to care for the at-risk population. Still, according to many Muslim countries, including Bangladesh, consider suicide and suicidal attempts as a punishment, criminal offenses. It could be assumed religious faith would discourage suicidal behavior in Bangladesh, but evidence shows otherwise. The decriminalization of suicide and suicidal attempts could be carefully united with the suicidal prevention initiative. Empirical data doesn't necessarily support the suicidal rate are lower in countries where suicide is a punishable offense. Rather, it is tendency to deliberate under-reporting, which keeps the rates minimum. The socioeconomic and cultural and religious context of Bangladesh, it would be advisable for policymakers to consult the widely and thoughtfully about the pros and cons of decriminalization, suicide and its attempt before enacting national suicide prevention strategy, so it doesn't hamper the expected policy outcome and other associated issues, such as data registry, support interventions. So despite these barriers, Bangladesh has approved, the National Health Strategy Plan 2020-30, the National Mental Health Policy, the National Mental Health Act, that is the 100 years ago. This is a excellent innovation of Bangladesh enacting the law. So all this happens with the prior guidance of Ms. Saima Wajid. She's the advisor to the WHO Secretary General of Mental Health issue, and we approved the mental health strategy. That is, Bangladesh is ready to address suicide as a serious public health concern through the systemic and comprehensive policy interventions. And our mental health strategy is really a specific, inclusive, and robust mental health. And we are going to implement another fifth SP-NSP sector-wide program. The sector-wide program is a operational plan that is planned for the 5 years development. And this is the first time that we are going to get the approval for a dedicated mental health and disability operational plan that is really dedicated for this issue, to address this issue only. So I hope all of this strategy and vibration for from the public and private partnership and our government and non-government organization will really overcome such issue. And I think decriminalization will be robustly changed in some days in Bangladesh in near future.
Fantastic. That was really a real overview there. And again, I think what's really striking is the amount, the volume of work going on. I think you've been making such strides. And I was speaking to one of your colleagues about this just yesterday, or no, earlier in the week, with regard to the YAS. We have a podcast series on decriminalization. So what really struck me was that you still that impact of the penal laws over 100 years ago still having their impact today. And I think so that really highlights the scale of the challenge. So thanks a million for that. Now, before I move on to our next panelist, so you may have noticed when I did the introductions at the start, I only introduced 3 panelists because our 4th panelist has just joined us, and it's Suzanne. Do you want to say a couple of words of just saying who you are? And thanks. I know you're running late, I knew, so thanks. But yeah, who are you? Tell us who you are.
Hello, everyone. Sorry, I'm late. So I'm Suzanne. I'm from Malaysia, Lifeline Malaysia. So I am I'm the vice president of Lifeline. Yeah. So we have a helpline in Malaysia, which is the suicide prevention helpline. And later we will share a little bit of how's our progress. We have some interesting progress this year. Yeah,
Great.
in Malaysia.
Fantastic. I'll come back to you in a few minutes' time, Suzanne, when we're asking you a specific question about the work going on in Malaysia. But for the moment, thanks, and it was great that you're able to join us. So we can move now to our third panelist, Mark Senior. Mark, so the question for you is, can you tell us a bit about the YASP's work on the Partnerships for Life initiative, which is one of our flagship policies in the International Association for Suicide Prevention, and tell us a bit about how it's that initiative is supporting the development and implementation of national suicide prevention strategies, obviously across the globe. It's doing across the globe, but in particular, be focused on low and middle income countries, and maybe also tell us a bit about how it's helping in situations or countries where suicide remains a crime.
Thank you so much. It's such an exciting intervention that we're starting here with Partnerships for Life. I think organizations like PAHO, which you heard from Dr. Oliveira, have been ahead of us for many, many years in terms of connecting all of the countries in the world. And I think that there was a recognition at YASP, the IASP, several years ago that suicide prevention research and our community was really collected mainly amongst high-income English-speaking countries. And of course, we know most countries in the world are not high-income countries, are not necessarily English-speaking countries. And if we want to, and in fact, we know that 75% of suicides worldwide occur in low and middle-income countries. And so there was an increasing recognition of the importance to really create a global partnership. And so Partnerships for Life is divided across the 6 World Health Organization regions. As mentioned, the one that I work on is the Americas. And there are many countries in the Americas, as I think you heard. There are 35 countries plus a number of dependent territories. And so in terms of the sort of the sequence of steps, the first thing that we decided to do was to try to form the partnership. And we've been quite successful. Over the last year, we've recruited 200 partners across almost all of the 35 countries, not quite all of them yet. We've had a number of meetings. We've held workshops in which different countries have presented either about their national suicide prevention strategies, if they have them, or if they don't have them, just about what activities in suicide prevention there might be or what gaps exist in suicide prevention. And we're currently working on a situational analysis so that we'll have the first comprehensive document which tells about everything that's going on with respect to suicide in all of the countries. And the goal then is really to try to leverage that. So for example, Dr. Oliveira mentioned that Guyana had recently decriminalized suicide, which is an amazing outcome. To be perfectly honest, we probably wouldn't have known about that as an entire suicide research community around the world, certainly not immediately without the partnership. So the advantage of the partnership is we found out the day that it happened. We knew it was in the works. It was disseminated across everyone. And the goal going forward is then to see how do we then work as a group to try to push forward some of these key outcomes. So for example, could we use that as a jumping board? For example, there are still countries, I believe, for example, the Bahamas and El Salvador, different countries that are in our region who still have a criminalization of suicide. Can we now as a group get together and say, look, this is what Guyana has done, one of your neighbors. Can you bring things up to speed and try to do that as well in your country? Is that something that we can try to push for as part of our partnership? And of course, you mentioned the key point in your question that the original kind of thought behind the Partnerships for Life was around promoting national suicide prevention strategies. And so that's going to be really at the top of the discussion, is how do we help facilitate that? How do we help facilitate components of those strategies? So an example is that the Ecuadorians are trying to set up a more comprehensive crisis line, and they have limited experience doing it. There's a lot of experience in Costa Rica. And so as part of the partnerships, we actually connected Costa Rica and Ecuador to try to have some mentorship around that specific issue. And the question is how to continue to propel this as it goes on. It's still early days, but it's a very exciting initiative, and looking forward to telling more about it over time.
No, great, Mark. And I think, again, from the YAS perspective, I think what's really struck us as an organization is how much that initiative has already made a difference and starting to make a difference. And it's, as you say, very early days. So we'll look forward to reporting more on that in due course. And as I just obviously pointed out my other deliberate error, when I said there's only 4 panelists, I meant 5 panelists. So we'll back to our 4th panelist. So Judah, over to you this time, and then we'll come to Suzanne. So Judah, question for you is, why are youth advocates so important stakeholders in advocacy with regard to suicide prevention and decriminalization? And can you maybe tell us a bit about your experiences, about your own advocacy work on such issues in Kenya?
Thank you so much, Rory. As we all know, I think it's the youth that are invariably affected by suicide. And a lot of suicide completions are reported amongst the young population. And in countries such as where I come from, like in Kenya, the reported cases are only a fraction of what's happening because of the whole shame that surrounds the whole topic. So if we are seeing reported cases rising, we are seeing other cases also continuing in the village settings and community settings. So I think for us, and for me personally as a youth advocate, that first-hand experience of growing up, going through these issues, going through change in the world, and seeing how it's affecting you and how it's increasing suicide completion, that is something that we can get data from. We can be able to have the youth themselves speak up and say, this is how this change is affecting me. This is how I felt. And also, for the youth, we are able to break through the peer barrier. Again, in countries, in low and middle income countries where it's very shame-based and very bound to some conversations that are not really about suicide, but anytime we are bringing up the topic of suicide, we're going to different areas and we are really like tiptoeing over that topic. We can be able to break through this peer barrier very easily because these are the same people experiencing the same things and they can be able to support each other very well. And also, the youth are the people in the universities. They are the people in the colleges. They're the people in the community who are doing such an amazing work and are living through the day-to-day and interacting with the community itself. And one of the things about decriminalization, it doesn't just work by policy, especially in very community-based places. So if we have young people in the community also supporting this and going from house to house and telling people, this is my experience, this is how I'm facing this. We can have suicide survivors saying that this is my story, this is why I got to this point. And we can also have youth advocates who have had friends who have died by suicide, unfortunately, or families, and being able to have this community support, supporting the people who are making the policies. Because then now the community embraces that this is not a topic for parliamentaries or for groups that are informing the president, but it's more of my topic. How can I relate to this topic and how can I be able to forward or do some action here? So youth advocates are really good because they're integrated in our families, we're integrated into the community, we're integrated into the institutions. So if we are pushing for suicide decriminalization, it becomes a personal view and not just a policy view. For me, what I do as the youth engagement officer is one, educate myself a lot because when you're living in the low and middle income countries, you have a multifaceted challenge because you're dealing with economy, you're dealing with low quality education resources, you're dealing with maybe lack of resources themselves. So you have to find a way to be able to know what is it I'm dealing with and how am I able to share it with my peers. So educating myself and leading charges of in education such as quality rights. Everyone embraces human rights as a concept. And when we're challenging suicide, stigma, and discrimination, and then decriminalization, it becomes very important to connect it with topics that people understand and value. So like the quality rights work that we do is engage, teach people about mental health from a rights-based perspective. And this now brings up conversations about, okay, so are we doing something about suicide decriminalization? Because now we know that it's against people's human rights and we're not helping them at the point of their need. And this education does not just come from institutions or certified courses, but also intrinsically. Listen to other people, listen to their experiences, listen to their challenges, listen to suicide survivors, listen to the peer the peers of people who are going through challenges and be able to see, am I able to change something in my life, one aspect of my life or my community that can better support someone else going through something, or can better support myself going through the same thing. And then also participating in suicide forums. Yes, I have an avenue where I can be able to teach others, but also it's good for me to support people who are forwarding the suicide decriminalization effort. So if there's a petition, I sign it, I send it to my friends, I send it to the people I work with. If there is a parliamentary discussion, I go and participate there and say, okay, this is me and this is my experience, this is what I can bring to the table. Because most of the times we find as youth, you feel sometimes unqualified to go and speak in those forums, but then your experience, your lived experience is a very important tool that can be able to change the scales of where these discussions are heading. So also going and participating in these discussions is very important. So in a nutshell, that is what I kind of do. And over to you, Rory. Thank you.
I liked your nutshell there, Judah. That was a great nutshell. And no, I think as a field, I think we were a bit slow in getting off the mark and involving youth in the work that we do. I think there was a lot of fear which stopped us. But I think we've now got to a place where we've got systems in place, mechanisms, way in which we can do that in a safe way, because it is important that the voice is heard, but that it has to be in a safe way, and that partnership is key. So thank you for everything that you do. It really is fantastic work. So move on to our fifth panelist, back to Sue Sain. And Sue, your question is, you mentioned in your intro, obviously, the crisis lines. And so they're really important, as we know, for suicide prevention activities across the globe. And in Malaysia, of course, you've recently decriminalized suicide. And so I suppose I'm curious, so will there be a change, or has there been a change in the way the crisis line in Malaysia has been able to operate and provide support in light of the decriminalization? And then secondly, what roles can crisis lines play in advocacy on issues like decriminalization and suicide prevention?
Okay. So for the first question, I would see at least in Lifeline Malaysia, the numbers of call are getting higher. Okay. After the announcement of decriminalization of suicide, so the number of calls are higher, and the numbers of high-risk calls is higher. Okay. And then I guess one thing is that because before May, there's a lot of anxiety among the volunteers when it comes to whether or not we should report to the police if that is a life-saving issue. You see, so for us, there's always have to think and to make sure that it's really high risk. Then only we will make the call, and we'll make sure that, because we do not want the caller to be put under a stress, a very high stress level, because we are not sure what the police will do, we are not sure what the hospital people will do, and there are a lot of anxiety even among the volunteers. Obviously, after May, we are more confident in handling the calls, because we can actually tell the callers some of the things that he or she can do, although there's still some level of anxiety, because the thing is, yes, we already say you won't be penalized, all right, but then what are the action mechanisms that is in place in the hospital or in the authority? We are not entirely sure, because we work in a situation whereby the government and the NGO, the helpline, they don't really communicate with each other, and we are trying to work out something whereby now the government and also the NGO, especially the helplines providers, we can start to engage with a dialogue. Yeah. So hopefully a working paper, or we can develop a working paper where we can tell them like our demand and our challenges, and so that we can we can work out a proper mechanism to help not just the caller, but also their family members who needed the support from us.
Yeah, that's really interesting, that changed, and thanks for that update. Is now being able to move the focus not just on the individual in distress, but that wider network, and including the family. And I think that's been really interesting to see how that develops over time. Okay, so thanks to our 5 panelists for really answering really interesting, great answers to those wide-ranging questions. So we've got some questions now in the chat, and I'll try and take a couple of those now. So if you have any particular questions for our panelists, could you please drop them on the chat, and we'll try and cover some of these. I'm going to start with one here, which I'm just trying to summarize. I'm going to go to first Renato and then Shahidul for this one on. It's to do with a question on, right, so we know the suicide rates are increasing in some countries, and there are policies in different levels and different states of implementation, and often the pushback is the fact that they don't feel culturally correct, as the question talks about, that the policies are not culturally correct. I'm just wondering from both, maybe Renato first, on your experience, what can we be doing to try and, because that is a real challenge, is that building that cultural element and to ensure the policies are acceptable?
Yeah, thanks for the question, Professor O'Connor. I think there are different elements that have to be taken into consideration here. Well, each and every country needs to have a strategy and a plan that addresses the specific situation in the country. So the work that we do with the country usually starts with a situation analysis. So let's try to together better understand, are there specific groups in the population of the country that is more affected than others? Are specific means of suicide that people use and have easy access? But it's also important to remember that suicide prevention is very intersectoral. So we as health professionals, it's very important that we take the lead, but we need to be able to bring on board other groups, other secretaries, other ministries that can help us to tackle specific areas that are shown as very important in the situation analysis. So I think that's an important way to start, because starting right is fundamental. And I think it's also very important to take into consideration, and we have done an exercise here looking into the strategies and plans of actions for suicide prevention in the different countries in the Americas. Well, first of all, there is still a good number of countries that need to put together a suicide prevention strategy and plan. So that's an important exercise. And I mentioned a good way to start, which is by doing a situation analysis. But for the countries who already have those suicide prevention strategies and plans, when we look at those plans and strategies, many times we found that key evidence-based or evidence-informed interventions were not integrated into those plans. So yes, it's fundamental to do the necessary adaptations, but it's also very important that we use the best knowledge that we have now to advance suicide prevention in the countries. So I think these are important elements to be able to advance suicide prevention in the Americas and globally, in fact.
Great, no, thanks for that. Shahidul, have you anything to add to that from your experience in Bangladesh and sort of navigating the cultural tensions often?
Okay, thank you, sir. The thing is that, the people of Bangladesh is culturally heterogeneous. So here is the progressive people, a big portion is fanatic people. It's a mixed like something. So adopting something beyond the religious boundary is very difficult in Bangladesh. So modification of law is important. In that case, we need to first talk with the lawmakers, the member of the parliament, the administrators. We need to make the advocacy to the religious leaders. We need to have the awareness to the general people. And I think we have to have the partnership and collaboration to the country or organization abroad who are success in this field, that is decriminalization. So it can be another statement for me that setting some conditions by WHO can be by taking decisions centrally to disseminate to the member countries such as Bangladesh, like these things. It can be helpful. And another thing is, the government, the approach is not sufficient enough for the to do such great things. So in that case, private and non-private organizations, that is non-governmental organizations, have to work in an orchestra, that is synchronously in such a state. So we are actually optimistic from that in the 1st July, that is the next year, the new operation plan will be installed, and we hope that there are a lot of things, and we focused on suicide in our best effort. So let us see, and we will be incorporated with you people to get the access, opportunity, knowledge, and everything. So we need all of your help. Yeah.
Thanks a million. No, it is a plea for all of us. We all have to work together, really, across countries, boundaries, sectors, backgrounds, to really tackle this challenge. The next question I'm going to start with Mark on the next question, and Judah, and then I have one question after that for you, Suzanne. So, Mark, the question I'm going to try is, I'm trying to sort of synthesize a question here, which is looking at suicide risk amongst high-risk adolescents, and the question is really around what are the new initiatives, or what's the evidence-based initiatives which seem to be effective in that population?
It's a good question. I mean, I'm an adult psychiatrist, but I do a bit of research in adolescence, and I tend to think in this area that we should always think back to first principles. If you look, for example, at the WHO's Live Life initiative, think about things like means restriction. So limiting package sizes of over-the-counter medications, making sure that firearms aren't in the home, and so on. It's obviously going to differ depending on the country and the common methods that occur. But something like that will prevent suicides in young people. I'm thinking of Thomas Niederkrotenthaler's study of the Logic song in the US, which was a song directed at young people about a young man who is a fictional character who's thinking about suicide and then chooses to call the lifeline and lives. After that was disseminated, there were 245 fewer suicides in the United States. So sending messages of hope and recovery to young people. School-based interventions, fostering skills. I think I saw that somewhere in the chat. We have one, if you want, I can put it in the chat that my group developed called myowl.org, which is free, and teachers can deliver it in the class, but you don't have to use ours. You can use any of them. The key point is that, people, actually, if you look at Professor O'Connor's IMV model, people get entrapped and stuck, right? That's kind of the central thing that occurs when you're suicidal. And so what you want is that young people understand that there are ways that they can handle situations so that they don't feel like suicide is the only option. And so giving a course or some sort of a series of techniques and strategies that young people could use, where they know that if they're in difficulty, they can access it even way before they might ever be in a suicidal crisis, is of crucial importance. And then the last thing, again, looking at the Live Life model, would be early detection. So my thought is really, even before young people might really become suicidal or be at high risk, trying to identify the ones who may become high risk in the next few years and see whether you could do a lower level and maybe even easier intervention to try to help them with coping skills and treatment so that that never happens in the first place. That would be the kind of model I would think about, but we could talk about this for hours.
Yeah, no, absolutely, and indeed, if we look at the evidence base compared to adults, the adult literature, it's so much smaller. The evidence of what's effective in young adults and adolescents is much more limited. But there is a bit of evidence, obviously, for peer mentoring programs from the SALE project from Europe, and also growing evidence again for dialectical behavior therapy for adolescents. But again, the DBT is obviously highly intense, and it's not available in many places. So there's one thing about what the evidence base is, but the other bit is accessibility. But then, as you mentioned, Mark, we can look at different areas and looking at different levels, like the Logic song in the US is a brilliant example of thinking differently to try and reach young people. So Judah, can I just bring you in there? And the other part of that question was looking at partnerships or partnering with schools. So I'm just wondering, in any of the work that you've done, Have you been involved in partnering with schools, and any advice you could give, or other youth organizations, and getting them involved in suicide prevention?
Thank you for that. I'd highlight first that what you said, Mark and Rory just said, we have limited evidence. And this is, I think, because of the fact that we are in a changing environment, and the things that affected adolescents 10 years ago are not affecting adolescents now. It's piling on. So yes, school-based interventions is really important. And as we know, most of the adolescents, even us or myself, when I was going through adolescence, I was not very willing to share what I was going through with everyone. So finding expressive engagement forms, make the music, make lyrics, make a poem, make a piece of art that describes where you are. Finding an expressive way for a young person to communicate what they're feeling, not only to the peers, not only to the professionals, but also to themselves. Because at times you find that a lot of the young people we deal with do not even have the language to say that I'm going through this and it's very hard for me. So giving that expressive engagement in schools and finding ways where the adolescents can participate themselves. This not only gives us the data that we require to say, okay, this is how a person looks like in crisis, but also gives us those points of creating alternative options to engage. And you can be able to see that this is something fun for the young people, and you can be able to maybe implement it in different sections. So yes, that's what I'd like to highlight. Thank you.
No, thanks. That's great advice. Okay, so time is up. We're marching against the clock, as always, in these webinars. So, Suzanne, just back to you. And actually, there's a question which relates really well to how you ended your sort of answer to your previous question, which, of course, is most helplines or hotlines or whatever term you use, crisis lines, are focused on the person in emotional distress. So what could we do more? How could we think of a model where we can involve and support the ripple effect of families, friends who are maybe impacted in either supporting somebody who's suicidal or dealing with the aftermath of suicide?
Okay. Just speak about Lifeline. All right. So Lifeline, what we does is we also provide case management for the family members who they have a family member who have called us and is a high risk suicidal call. So what we will do is we will contact the family members and also to provide the support for the family members so that they will know how to handle the children or handle the couple or etc. And also the other thing is, I guess for helpline, one thing about helpline is we sitting in the office to wait for the call to come. Okay, which it doesn't really help because we have to do a step further, which is the prevention. So what we does this year is that we have a program that we engage the adolescents, and then we make them to be to create a buddy system whereby they can talk to their groups, their peers. Because and especially now the children, the adolescents, they might not want to call us, but they will adopt other strategy, like for example text and all sorts of other different apps that we will have to engage. We cannot be like the conventional helpline, you know. So it's best to get the adolescent to help their group, okay, with our little support, and so that they can we can reach out to more people. And that is the very important thing when we talk about prevention. So it's better to start when they are young, you know.
Start when they're young is a great way to sort of end this section, and also the importance of trying to be proactive. We're better at being reactive, and when often it's maybe sadly too late for too many of our young people. So no, thanks for that, Suzanne. And so I just note in the chat, so apologies, we won't have time to go to the other questions, but really important questions on minority groups, on LGBT IQ plus individuals, on refugees, on asylum seekers, and other vulnerable individuals. So just a reminder that the chat you can continue the chat on Circle after the webinar. So I really encourage you. We've had over 90 people on this webinar today, and so really continue that chat, those who can, after this, and really to build networks, help answer those questions. Now, as we start to come to the wrap up, and I've just got this, as I said in my introduction, we've a quick fire question for each of our panelists, and I'll just go in the order in which I've been going thus far, from panelist 1 through to 5. And again, as I said at the start, at the top of the webinar, the focus here is on creating hope through action. So the question for each of our panelists is and you're only allowed a tweet length. So I'll give you 280 characters. I won't hold you precisely to it, but brief answers to the question or completing this sentence. And the sentence is, to drive action on suicide, we must ... So the first person is Renato.
We must make suicide prevention a priority at national political and development agendas, and ensure that it receives the appropriate attention and resources.
You've practiced that, I can tell. You've practiced that. So next we've got Shahidul. What's your answer to that one?
I'm agree with you. He is practiced, because I need to take 2 minutes at least, because what to say here about the academic question is very difficult in a single question. So the main thing is to decriminalize this suicide issue is first we have to own the problem. Here's the problem, and it has to be addressed, and we need to be committed. That's it.
Yeah, no, ownership I think is vital, but that ownership is we all have to own it. And I think that's a really important message indeed. Mark, over to you. Same quick answer.
Of course, I'll do my best. We need to work together, think big, act globally. Suicide is preventable. There is hope.
Yeah, brilliant. I mean, what a fantastic strapline. And also think global, work local as well. Obviously, having that interplay is absolutely key. Thanks a million. Judah, over to you.
Okay. We need to engage the community and make it a community solutions, engage all age groups, and foster that hope within the community.
Brilliant. No, fantastic. And that fostering, I think events like this, with the networks that we're building on webinars like that, are key to that fostering. And lastly, Suzanne, what's your end to that, the tweet response?
We must work together. Together we conquer.
Oh, I think it's not a competition. However, I mean, that was fantastic. I mean, absolutely. I think that's a great summary, which obviously that summarizes, I suppose, the other 4 responses in many ways. So obviously it's not a competition, but I suppose everything is a competition in some way or other. No, thanks a million, Suzanne, for that. And a huge thanks I have a couple of final bits, but a huge thanks to our panelists, and of course, all of you who have joined us for the webinar. And again, it's available, or the conversation can continue on Circle after this. And again, so many topics we were unable to get to. So huge thanks to everyone for taking part and making the time for this. And also just as a reminder that on the 14th of September, the World Health Organization launches their launch event, for their policy brief on decriminalization happens. So that's 14th of September, and the registration link should be in the chat if I can scroll down and see it. And then also just to remind you that the next webinar will be on World Mental Health Day planning. And once again, the registration link is in the chat. So on that note, I think the vibrancy of the questions, the vibrancy of our panelists really highlights the challenge. But it is a really, I think, an important and exciting and optimistic time to working in suicide prevention globally, because we have seen a lot of movement in the recent months and years. And let's all, as we work together and we'll conquer this challenge of suicide prevention. So thank you so much for your time, and have a great morning, afternoon, or evening, wherever you are in the globe.
Thank you so much. Thank you.
Thanks, everybody. Take care.
Thanks. Bye-bye.
Bye.
Thank you. Bye.